guys, welcome to my channel medschool. How are you doing? I hope you all are doing well. If you're new here, consider subscribing and hit the bell icon so that you don't miss out on the new videos. Without further ado, let's get started with the topic. Today we're going to study about a topic which is a subtopic of cardiovascular pathology called atherosclerosis, and here it is. Hey guys, don't freak out. The heading says arteriosclerosis. I know you might be wondering, like, he put the thumbnail as atherosclerosis and the heading of the video as atherosclerosis, but he's showing like arteriosclerosis. That doesn't make any sense. But you need to know that it, like past of atherosclerosis, or the what part, like to whom does it belong, atherosclerosis. So we need to actually know a little bit about arteriosclerosis before we move on to atherosclerosis. So here we go. Arteriosclerosis. It literally means hardening of the arteries. That is, arterial wall thickening and loss of their elasticity. There are three general patterns with different clinical and pathological consequences. Based on these, the clinical and pathological consequences in the patient, they are divided into three general patterns. The very first of these is arteriosclerosis, which affects small arteries and arterioles. There are two anatomic variants of these arteriosclerosis: hyaline and hyperplastic arteriosclerosis. Hyaline arteriosclerosis mainly is observed in patients with essential hypertension or diabetes mellitus, whereas hyperplastic arteriosclerosis is observed in patients with severe hypertension, and which can also show us there is severe smooth muscle cell proliferation in the blood vessels. The second is Monckeberg medial sclerosis. Now, this is characterized by calcification of the walls of muscular arteries, and calcification do not invade the vessel lumen and hence not clinically significant. The third of these is atherosclerosis. Now, this is the top thing that we're going to discuss further. This basically means narrowing of the artery due to buildup of plaque, and we'll look into what actually plaque is about soon. Atherosclerosis. Finally, on the stuff that we were going to study. It underlies the pathogenesis of coronary, cerebral, and peripheral vascular diseases and causes morbidity and mortality in very vast numbers. Atheroma and atheromatous plaque both are basically the same, the two faces of the same coin. It consists of raised lesions, intimal lesions, which are raised with soft grammus core of lipid. The main lipid which is present in the atheromatous plaque is cholesterol and cholesterol esters, which are covered by fibrous cap. Increased thickness or the distance from the lumen to the media, thus weakening the vessel wall, leading to aneurysm. The raised lesions, as you can see in the figure on your right, the cholesterol and cholesterol esters which are present within the atheromatous plaque impede the transfer of oxygen and other nutrients across the blood vessel wall, thus leading to weakening of the vessel wall, as they can't get any much nutrients, neither oxygen, hence leading to weakening of the blood vessels. Risk factors for atherosclerosis. The likelihood of atherosclerosis is determined by combination of acquired and inherited factors. The risk factors are basically divided into three major groups, which are constitutional risk factors, modifiable risk factors, and additional risk factors, which broadly categorize the risk factors into three different classes. We'll look into each one of them one by one. The very first is constitutional risk factors. Genetics play an important role in determining whether a person will be able to get the disease in the future because of their parents having it. One of the example is familial hypercholesterolemia. The hypercholesterolemia is a very important risk factor in the progression or the progress of atherosclerosis, as it builds up in the plaque And as you see, it is transferred from the parents to the offsprings, familial hypercholesterolemia, and other diseases such as hypertension, diabetes, which are also, you know, passed on to the offsprings, can also exacerbate the atherosclerosis progression, and thus leading to the person landing in atherosclerotic disease or atherosclerotic plaques having been formed in the blood vessels. The next factor is age. It is a progressive process. The atherosclerotic plaque formation doesn't happen overnight. It takes decades to, sometimes take decades, years, but it doesn't happen very soon. Uh, and until 40 and 60 years of age, the incidence of myocardial infarction increases fivefold. Myocardial infarction happens after atherosclerotic. In most of the cases, it happens after atherosclerotic plaque formation, leading to the occlusion of the artery. And as you see, after 40 to 60 years of age, up to 40 to 60 years of age, and after that, the incidence of myocardial infarction increases fivefolds. And death rate increases like rises with each decade passing by. The next is gender. Premenopausal women are protected from atherosclerosis compared to the men of the same age, until and unless they don't have risk factors, as we discussed about the hypertension, diabetes mellitus, and hypercholesterolemia. Till then, the premenopausal women are safe from atherosclerotic diseases, and it is very uncommon to find atherosclerosis in premenopausal women. But after menopause, the incidence of the disease increases. This is mainly due to the absence of estrogen. To test this theory, the scientists estrogen replacement therapy had been performed on postmenopausal women, but in fact the results were quite astonishing. The women who are just out of menstrual cycle after menopause, those women responded well to the estrogen therapy, whereas the women who are much more older than them didn't even actually respond to the estrogen therapy, and it was not quite beneficial to them. Thus, hence proving that estrogen therapy is much more useful to the woman, who's useful to the young postmenopausal woman, and not so much beneficial to the older postmenopausal woman. The second group of risk factor is modifiable risk factor, and it includes hyperlipidemia, which we discussed when we were discussing about genetical contribution to atherosclerosis formation. It more specifically, hyperlipidemia more specifically means hypercholesterolemia, and it's a major risk factor all alone, or rest other factors if not present. Hypercholesterolemia or hyperlipidemia alone is a very major risk factor for the progression of atherosclerosis. Increased risk is LDL cholesterol, that is low density lipoprotein cholesterol. What is it? LDL cholesterol is also called as bad cholesterol. Lipoprotein or apoprotein are used for transporting cholesterol in the body, in the blood, and lipids and apoprotein together form lipoprotein, and LDL carries the monounsaturated cholesterol, and HDL, high density lipoprotein, is considered as a good cholesterol. So the diet is very important in preventing atherosclerosis for progression, and increased LDL, the food which has increased LDL cholesterol when then compared to HDL cholesterol will definitely lead to atherosclerotic plaque formation. Exercise and moderate consumption of ethanol lowers the LDL level and increases the HDL level, which is basically good for preventing the atherosclerotic plaque formation. And obesity and smoking increases the HDL levels. And statins lower the blood cholesterol levels. Statins are the drugs which lower the blood cholesterol levels, and they do this by inhibiting HMG-CoA reductase enzyme in hepatic cholesterol biosynthesis. Now, the second modifiable risk factor is hypertension. On its own, it can increase the risk of ischemic heart diseases or IHD by 60%. The third is cigarette smoking. Cigarette smoking is a well-established cause of atherosclerosis in males and also accounts for incidence in women. the if cigarette smoking is left, or it's like they don't smoke anymore, then the risks fall substantially. The fourth is diabetes mellitus. It induces hypercholesterolemia, and the incidence of myocardial infarction is twice as high as in patients with diabetes than in those without diabetes, and it also increases the risk for stroke and 100-fold increased risk of having atherosclerosis induced gangrene in the lower extremities than compared to any other normal patient with diabetes. The third group is additional risk factors. 20% of the cases occur without any previous discussed factors. Clearly, other factors contribute to the risk of atherosclerosis. The very first of these is inflammation. It is present in all stages of atherogenesis and is intimately linked with atherosclerotic plaque formation. Then, how do you know whether inflammation actually causes this atherosclerosis? Check the level of CRP. CRP is a C-reactive protein which is synthesized in liver and is mainly present in the blood at the time of inflammation. CRP has emerged as the simplest way to measure inflammation. It is well established that plasma CRP is a strong and independent marker of risk for myocardial infarction, stroke, peripheral arterial disease, and SCD, sudden cardiac death, even in healthy individuals. The second is hyperhomocystinemia. Serum homocysteine levels correlate with atherosclerosis, stroke, peripheral vascular diseases, and venous thrombosis. Low folate and vitamin B12 can increase homocysteine levels in the blood, but providing vitamin supplements doesn't affect its cardiovascular incidences like atherosclerosis. The third is metabolic syndrome. Associated with central obesity, this entity or individual is characterized by insulin resistance, hypertension, dyslipidemia, hypercoagulability, and pro-inflammatory state. Yeah, people, everything that we were running away from. All of these present in a single individual, a perfect ground for atherosclerosis progression. The fourth one is lipoprotein A. Lipoprotein A is an altered form of LDL, basically same at their core, LDL bad cholesterol, which means increased levels of lipoprotein A is dangerous and is much more favorable for atherosclerotic plaque formation. Pathogenesis of atherosclerosis. Integration of the previously discussed risk factors gives us a response to injury hypothesis, a model which views atherosclerosis as chronic inflammation and healing process of the arterial wall to the endothelial injury. Endothelial injury is due to lipoproteins, hypertension, diabetes mellitus, and various risk factors as we discussed before. It progresses in the following sequence. Endothelial injury and dysfunction leads to increased vascular permeability. And the second is accumulation of lipoprotein, mainly of LDL, which insults and destroys or injures endothelium. The third is monocyte adhesion to endothelium. Monocytes adhere to the endothelium and they move their journey into the intima and then they convert into foam cells. Fourth is platelet adhesion. Platelet adhesion to mainly subendothelium. And the fifth is factor release, smooth muscle cell proliferation and recruitment of the T cells. Factor release is mainly from the adhesed platelets or activated platelets, and these factors recruit smooth muscle cells either from the media or from the surrounding vascular wall, leading to their proliferation and recruitment of the T cells, thus exacerbates the inflammation. Sixth is lipid accumulation. Lipid accumulation and mainly within the cells and extracellularly as well, cells such as within the cells such as macrophages and leading to foam cells and in smooth muscle cells. As we look into the diagram, these things get pretty much clear in the brain. The diagram is coming up right now. As you can see in the diagram, the endothelium is very much intact, but due to chronic endothelial injury and insults to the endothelial cells, such as hyperlipidemia, hypertension, smoking, homocystinemia, and hemodynamic factors, cause the destruction or injury to the endothelium, thus leading endothelial dysfunction and increased permeability of the macrophages, leukocyte adhesion, And as you can see, the macrophages in the third diagram, they enter within the intima and they start engulfing all the lipid accumulated in the intima due to the endothelial injury. And smooth muscle cells are also recruited by the factors released by the platelets, activated platelets, and they also start engulfing the lipids, thus forming fatty streaks. The accumulation of lipid and engulfed macrophages and smooth muscles in the intima gives us the expression of a fatty streak, the yellow colored appearance. And this thing eventually lead to the formation of a fibrofatty atheroma. Endothelial injury is a cornerstone in response to injury hypothesis. Etiological culprits include toxins from cigarette smoke, homocysteine, and inflammatory cytokines. Two most important causes of endothelial dysfunction are hemodynamic disturbances and hypercholesterolemia. Hemodynamic disturbances mainly includes the turbulent flow in the blood vessels. Plaques tend to occur at the ostia or opening of existing vessels, branch points, and along the posterior walls of abdominal aorta. Now, these are the places where the laminar flow is frequently disturbed and gets converted into turbulent flow, leading to the formation of thrombus, which eventually leads to atherosclerosis. Hypercholesterolemia. Lipids are transported by apoproteins by forming lipoprotein complexes. Hypercholesterolemia indirectly means increased cholesterol level in the blood, and dyslipidemias occur within hypercholesterolemia. Dyslipidemias are nothing but diseases or like the abnormalities in the general population considering with lipoprotein. Lipoprotein abnormalities are called dyslipidemias, and these are as follows: increased LDL cholesterol levels, decreased HDL cholesterol levels, and increased levels of abnormal lipoprotein A. Evidence implicating that hypercholesterolemia is involved in atherogenesis is that the dominant lipid in atheromatous plaque is cholesterol and cholesterol esters, and the genetic disease or the genetic disorders like familial hypercholesterolemia, and the individuals which have familial hypercholesterolemia, they tend to have much more prone to get cardiovascular events. And the blood cholesterol lowering drug like statin, when administered, these bring down the occurrence of cardiovascular events, and hence proving that hypercholesterolemia is a much more important risk factor or major risk factor in atherosclerosis or atherogenesis. Mechanism by which hyperlipidemia contributes to atherogenesis is that hypercholesterolemia, or indirectly hyperlipidemia, impair endothelial cell function by increasing local reactive oxygen species production. These local reactive oxygen species, radical oxygen species, this not only just destroys or damages membrane and mitochondrial damage, but the oxygen-free radicals accelerate nitric oxide decay. The nitric oxide is a vasodilator which helps in the vasodilation, and the decay of nitric oxide thus leads to vasoconstriction, which leads to turbulent blood flow, and then which eventually leads to atherosclerosis. And the second is hyperlipidemia, leads to accumulation of lipid in the intima, which further leads to formation of foam cells. As there is increased lipid content in the blood, LDL mainly, it gets deposited or aggregated in the intima, and where it is converted into modified LDL. It gets converted into modified LDL due to the presence of oxygen species, and this modified LDL is then accumulated by macrophages and smooth muscle cells, and they get laden with these modified lipid within them, and they're called foam cells. And these things, they just accumulate within that area, thus leading to occlusion of the artery or the vessel in which they are present, and hence leading to atherosclerosis. Inflammation. Chronic inflammation contributes to the initiation and progression of atherosclerotic lesions. Inflammation is mainly triggered due to the accumulation of cholesterol esters and free fatty acids within macrophages. Inflammasome activation leads to the production of pro-inflammatory cytokines interleukin-1, which recruits leukocytes including monocytes. T lymphocytes are also activated. The activation of macrophages and T cells leads to the production of cytokines and chemokines, which further increases the inflow of inflammatory cells. Activated macrophages produce oxygen species that enhance LDL oxidation and elaborate growth factors that drive smooth muscle cell proliferation. These leukocytes and the growth factors which got elaborated and vascular walls release growth factors that promote smooth muscle cell proliferation and synthesis of extracellular matrix proteins. Thus, many of the atherosclerotic lesions are attributable to chronic inflammation, smooth muscle cell proliferation, and matrix synthesis. Enytimal smooth muscle cell proliferation and extracellular matrix deposition convert a fatty streak into mature atheroma and contribute to the growth of atherosclerotic lesions. What is a fatty streak? Fatty streak is just an area or a place or streaks in blood vessel which mainly contain lipid-filled foamy macrophages. Well, as you can see in the figure, the hyperlipidemia, hypertension, then smoking and other influences leads to endothelial dysfunction and injury, which leads to platelet adhesion and a release of the activate factors by the platelets, which leads to accumulation of monocytes, T cells, and all the inflammatory cells, leading to their progression into intima, where macrophages engulf the lipid molecules and then lead to their oxidation and then conversion of the LDLs to modified LDLs. And these modified LDLs are also taken by the incoming macrophages and smooth muscle cells through the receptors, and these engulfed lipid-laden macrophages and smooth muscle cells accumulate in the atheromatous plaque and leads to the formation of fatty streaks. And there is increased proliferation of smooth muscle cells, and extracellular matrix synthesis is also increased, leading to the formation of a fibrous cap which covers the atheromatous plaque. Consequences of atherosclerotic plaque. The target of atherosclerosis is large elastic arteries, medium and large muscular arteries. Myocardial infarction, cerebral infarction, aortic aneurysms, and peripheral vascular disease are all consequences of atherosclerosis. Features of atherosclerotic lesions are acute plaque change. Plaque erosion or rupture is typically promptly followed by partial or complete occlusion of the artery. Three general categories under which the plaque change falls are rupture or fissuring, exposing highly thrombogenic plaque constituents; erosion or ulceration, exposing the thrombogenic subendothelial basement membrane to blood; hemorrhage into the atheroma, expanding its volume. Plaque rupture occurs when they are unable to withstand the mechanical stresses of the blood. Events causing plaque rupture are complex, including both intrinsic and extrinsic factors. Composition of plaque plays an important role in its rupture. Collagen is the major structural support of the plaque, that is, of the fibrous cap. A balance between the synthesis and degradation of the collagen affects the integrity of the plaque. Loss of smooth muscle cells leads to loss of collagen, which further weakens the fibrous cap, hence leading or making it to rupture in future. Collagen turnover is controlled by metalloproteinases. Metalloproteinases are modulated by tissue inhibitors of metalloproteinases produced by macrophages, smooth muscle cells, endothelium. Inflammation induced by cholesterol deposits themselves may contribute to plaque destabilization. Statins thus have a beneficial effect, just not only of decreasing cholesterol levels but also of stabilizing plaques. Influences extrinsic to the plaque can contribute to changes like adrenergic stimulation, can increase systemic blood pressure or vasoconstriction. Adrenergic stimulation and vasoconstriction are extrinsic factors to the plaque which can contribute to the changes, thereby increasing physical stress on the plaque. increased intense emotional stress can also contribute to plaque disruption. And vasoconstriction is like narrowing of the blood vessels, thus putting more pressure on the plaque and thus can potentiate plaque disruption. Vasoconstriction at sites of atheroma may be stimulated by circulating adrenergic agonists, locally released platelet contents, imbalance between nitric oxide and endothelin. Nitric oxide is endothelial derived vasodilator kind of stuff, and endothelin is endothelium derived contracting factors. An imbalance between these two vasodilators and constrictors leads to vasoconstriction. And it is also important to know that not all plaque ruptures result in occlusive thrombosis with catastrophic consequences. Atherosclerotic stenosis. Stenosis means narrowing of the blood vessel, and in small arteries, atherosclerotic plaques can narrow the or even occlude the vessel lumen. Critical stenosis. It is the stage at which the occlusion is sufficiently severe to produce tissue ischemia. In coronary circulation, this typically means 70% decrease in the cross-sectional area. With this degree of stenosis, stable angina may develop. Stable angina is one of the form of angina pectoris. Strength of the fibrous cap determines the fate of the plaque. For example, if you see in the figure, it's a vulnerable plaque and stable plaque. Vulnerable plaque mainly contains much of the foam cells and extracellular lipid and very less smooth muscle cells in the fibrous cap and more inflammatory cells in the fibrous cap and frequent remodeling of the fibrous cap, thus leading to its vulnerability to rupture. Stable plaque, whereas stable plaque contains less foam cells and very much smooth muscle cells in the fibrous cap and less extracellular lipid, thus leading to its stability. Hence, it may not rupture yet. So, this is it about atherosclerosis. I hope you enjoyed the video. Don't forget to subscribe and hit the bell icon. I'll keep bringing such informative videos to you. Until next video, bye bye.